So FND is my main interest. I do 2 FND clinics a week, and I'm clinical lead with an FND service at Southmead. I also do a general neurology clinic and a cognitive neurology clinic. And my out-of-hours work is in stroke, so juggling quite a few different things there. So just thinking about functional neurological disorders, I'm sure you're all aware, this is when people experience neurological symptoms that there's no underlying damage or harm to the brain or nerves. Instead, there's a problem with that function. So that's why we call it functional neurological disorder. And the most recent iterations of the diagnostic manuals have both removed the need for psychopathology, which is in keeping with our current understanding of FND. About 50% of FND presentations are functional movement disorders. That might be functional weakness, tremors, dystonia. About 30% functional seizures, which used to be known as non-epileptic attacks. And then there's a whole host of other symptoms. That might be speed problems, swallow problems, sensory problems, and cognitive symptoms. So I often do animations, so it was just a little attempt. So cognitive symptoms are really common. Pretty much everybody with functional symptoms has cognitive symptoms in their symptom mix. And the kind of symptoms that they'll report are problems with their memory, problems with attention, concentration, word finding difficulties. And now I'm just going to think about why we should worry about functional symptoms, in particular functional cognitive symptoms. And when I had been trying to develop the functional service over the last few years, I sometimes get comments from my consultant colleagues that perhaps we should be prioritising precious resources for people who've got real and neurological conditions. It should be trying to recruit physiotherapists to help people with MS rather than people who don't actually have a problem with their brain. So I think neurologists in particular do worry about FND, but perhaps reasons that we don't need to worry about. So we worry about misdiagnosis, we worry about missing a diagnosis of an organic condition that needs different treatments. But actually long-term studies show that we're really good at diagnosing FND. So we get an FND diagnosis wrong less than 5% of the time. So that compares favourably to, as Jonathan was mentioning, for Alzheimer's or dementia, which we might get wrong 30% of the time. We're also worrying about lingering, so it's really rare. I think I can confidently say in my FND clinic, I don't think I've seen anybody who I think is malingering. And Professor Mike Eckert, he's a movement disorders neurologist in London, has written a wise paper about this in Nature. So why should we worry about FND? It's really common. So it affects about 1 in 6 patients that we see at the general neurology clinic. And regardless of what we think the cause of the symptoms are, they cause disability and distress that's on par with other neurological conditions. It tends to affect people of working age, particularly females, and people with psychiatric comorbidities are more likely to develop them. But we need to be careful about stereotyping. And what about cognitive, specialist cognitive clinics? So this is a figure from a review article by Laura McWhirter. And Laura McWhirter is a consultant psychiatrist in Edinburgh. She's recently completed a PhD on functional cognitive disorders with Alan Carson and Joel Stone. And she reviewed 30 studies of the incidence of functional disorders in specialist clinics and found that on average 24% of presentations have symptoms in keeping with functional cognitive disorder. And as I said, functional cognitive disorders pop up in other scenarios, so in the FND clinic, but also in pain clinics, brain injury clinics, fatigue or fibromyalgia. People often report brain fog, and that has a similar cognitive profile to functional cognitive disorder. Functional neurological disorders are costly to the individual. Symptoms often intrude on daily life and might not be able to go to work, and then that will have a lock-on impact on society. They might need benefits or carers. And FND falls under the umbrella of medically unexplained symptoms, which are said to account for up to 10% of the NHS budget. In general, people with functional symptoms have a rubbish experience. Obviously, they have distressing symptoms, but interactions with healthcare can be difficult. So this is a survey by FND Hope, which is an international PS4 group. And they surveyed about 500 invalids from all around the world and found that the vast majority of them had felt that they'd experienced stigma relating to their diagnosis, or that they'd felt dismissed. Actually seen as dismissed or disrespected when being seen by a healthcare professional. These patients are also at risk of iatrogenic harm. So said doctors are worried about misdiagnosing people with a HED when actually they've got another problem, but actually what's more common is that they're misdiagnosed with the other problem. And so we'll see there's the psychological harm of being told that they've got a potentially progressive disabling condition, possibly life-limiting, and often you've got to do without a good treatment. Or they might be exposed to incorrect treatment. So there are small small number of case reports of people actually dying as a result of being over-treated status epilepticus when actually they're having functional seizures. And then there's the iatrogenic harm that comes with a diagnosis of FND. There's often a long delay to getting a diagnosis, often exposed to multiple investigations in our way. There's the stigma that I talked about from the FND Hope study of having the diagnosis. Doctors are often unaware of any treatment options and often discharge people with ongoing symptoms. And then people often report they don't have had any new symptoms, even affecting other bits of their body. It's often lumped together with the FND diagnosis. And then this is for managers in the EDs. I'll get that moving. So this is a study from Leeds. The writing is difficult to read. So the little yellow cobs are people with FND. The grey box at the top is the emergency department. The box to the right is that. In blue is inpatient neurology. And down at the bottom on the left is outpatient neurology. And in between is lots of investigations. And you can see people just going round in circles. And the only way to go out of this is to get a diagnosis of FND and treatment. And then in hearing, there's lots of interesting research in cognitive disorders. And what we don't want is DQ functional cognitive disorders involved in research into neurodegenerative conditions. Obviously, their structure is going to be different and their response to treatment is going to be different. And if you look at the inclusion and exclusion criteria for recent trials, you'll see that they want people who've got a progressive cognitive deficit, positive biomarkers, and other conditions have been excluded. None of them that I can see specifically mention functional cognitive disorder. There's another review article from Laura McLeod on the right. This diagram is taken from that. And you can see that there's up to rate between visual cognitive disorder and subjective cognitive impairment and MCI, and that people with functional cognitive disorder can get false positive biomarkers. So it's really important that we develop better diagnostic criteria for identifying functional cognitive disorders. We stop people with functional cognitive disorders getting swept into clinical trials and distorting results. So I've got a couple of cases that I wanted to intersperse on the next few slides. There's two cases. One is a classic FND case with multiple symptoms, and then the second is a more pure cognitive presentation. So the first is a 30-year-old right-handed male, and he was otherwise felt he'd had an episode depression and anxiety about 10 years before the onset of his current symptoms. He was working, living at home with his wife and daughter. He'd stopped smoking during this illness and was looking at interested in his social family history. Everything was going well for him. In late 2018, he'd got a new job and they'd moved into a new house. And then in December, he developed a chest infection. He was at home feeling unwell with this when he suddenly felt that something bad was going to happen. He developed some sensory symptoms in his left arm, couldn't speak, and his brain collapsed in a chair. He was taken to his local stroke unit where possibility of stroke was considered. He had a CT head scan, which was normal, and he was thrombolyzed. He was admitted to the ward, and the next day, once the dust had settled, sort of recognised that it wasn't a classic stroke presentation. And so he was referred for an MRI, which was negative, and at that stage, you'd expect that to pick up a stroke. So he was told that he hadn't had a stroke, and he was given a diagnosis of FND, but as it was explained as a stress-related condition, and that made no sense to him. He was discharged without any therapy or follow-up. And then the second case is a more cognitive presentation. So this is a 65-year-old white-handed lady who'd had chronic fatigue since an insect bite in the 1970s. She had mild bilateral cataracts. She worked in the NHS as an administrator. She was university educated. She lived on her own, nothing else interesting in her social history. Her mother had developed dementia in her 80s and died at 90. Her father was otherwise well and died at 94. And her younger sister has schizophrenia. And actually looking back through genetics, there was mention of break for him in consultations back in 2008. But her current cognitive concerns started acutely in 2019. She was in the street and she had prolonged eye contact with somebody that she wasn't sure whether she recognised, and it turned out to be a colleague from work, and she found that incredibly embarrassing. And shortly after that, she developed some problems with her vision. She felt disconnected from what she could see. She liked going to a choir. In fact, she couldn't do that anymore because she couldn't read the music and she couldn't interpret what conductors was doing. She developed memory problems, so she bought a long list of these. She bought the same item twice in a single shop. She'd left things out overnight, doors unlocked, led shopping in the car boot that she discovered a few days later when she'd gone there for something else. She'd nearly missed paying the bill, which was really shocking. She had word-finding difficulty. She had to really concentrate to recall distant memories. She also had a headache and wasn't sleeping a while. So I'll come back to both of those. So now I'm just going to have a think about how functional symptoms come about, and in particular functional cognitive symptoms. So I've just got a couple of people up here to represent neurology and psychiatry. So if I was in a small group, I'd see whether people recognise anyone. Let's say on the left, we've got Charcot representing neurology. So French neurologist, known as the father of neurology. He was really interested in FND. It's known as hysteria at the time, but he did a lot of research into it, but didn't really manage to pass on that interest to his neurological descendants. And so FND or hysteria moved over to psychiatry. And so that was Freud there, perhaps some feedback with your key on being represented by Freud. I think he's not too popular in the FND world. But I just got the two here to represent what would happen, particularly in the last century. With a patient, they'd have neurological symptoms, be referred to a neurologist who would assess them and say that there wasn't a neurological problem, and maybe they needed to see a psychologist or a psychiatrist. And that was helpful for a lot of people, but not for everybody. For the people it wasn't helpful for, the psychiatrist would be like, it's something with neurological symptoms, so they'd send them back to the neurologist, who would say, there's nothing wrong with them. And so Mark Edwards in London has coined this. There's an anti-therapeutic game of ping pong between neurology and psychiatry. And so people with functional symptoms would fall between the two specialties with their disabling symptoms. And that was really the case until the turn of this century, when we have John Stowe, who's a neurologist in Edinburgh, and who was a registrar and training as a registrar. And realised that he see loads of people with functional neurological disorder at clinic. And he did the epidemiological studies that showed that it's really common. So 1 in 6 figure comes from his studies. And that's being replicated across the world. And so he felt that neurologists really needed to take more responsibility for these people with neurological symptoms, and really kick-started research into FND from the turn of this century. And then during this talk, I already talked about Laura Lettwater, but I'm also going to refer to studies from Harriet Borg, who's a consultant neurologist now that's in Bristol, and also Veronica Cabrera, who's a Portuguese neurology trainee, who's just completed her PhD with John Stone in functional cognitive impairment. So just thinking about how functional cognitive symptoms come about. So you'll all be familiar with cognitive lapses are part of normal human experience. Laura McGuire has done a study on that on the left, on 127 adults, and just showed the frequency with which we have cognitive lapses on a day-to-day basis. And I think doctors, when they're talking about functional symptoms, often reach for a stress explanation of functional symptoms, because that's the context that we all experience as functional symptoms. So you will be familiar with sort of your mind going blank, not being able to remember a PIN number, or during your medical training, being asked a question on a ward round, and not being able to think of anything at all. And then there are other stressors which affect our cognition, and Jonathan talked about these as well. It's important to identify these factors in the history, because they'd be helpful to use in your explanation to the patient of the kind of things that might actually be impacting on their cognition. Most of them that are potentially modifiable, and all of them are potential risk factors for actually developing dementia in the future. And just going back to the traditional risk factors for AD and thinking about adverse life events. So this was looked at in a meta-analysis in Lancet Psychiatry in 2018. And there are lots of ways that you can read this paper, but one take-home message is that about 50% of people with FND have experienced adverse life events. So rather than telling people this is a stress-related condition, one might say that it's sort of 50-50 and see whether they feel that that relates to them. And I'm using these slides to teach resident doctors who might not be psychiatrists with GNAGUT that often the trigger for developing functional symptoms is a physical illness or injury. So you can stay in lane as a medic and pick out those factors. So everybody can experience cognitive lapses. They might be made worse by particular stressors or risk factors, and then that could be compounded by negative illness beliefs. So having cognitive lapses can be embarrassing and it might worry people that they're on a slippery slope to developing dementia. And that can lead to extra attention on their cognition. And once we start to notice problems, we start to notice more problems, and then we lose trust in our automatic cognitive processes, which are actually really efficient. And we move over to more peripheral conscious processes, which are less efficient. We're more likely to make mistakes. And so it gets the course of this vicious cycle of accruing cognitive symptoms. And so then you start to think that maybe you have got dementia, and when you think that maybe you've got dementia or you develop them dementia, you're more likely to feel like you have nothing, that's due to the expectation effect. And often when I was talking about functional neurological disorder, I end up talking about illusions. Illusions are, again, another situation in which we experience functional symptoms. So what we experience about the world isn't what's actually happening. And illusions are based on the fact that our brain works as a predictive machine, and they're based on our previous experiences, expectations and beliefs. Often it's second-guessing what we're going to experience. And if what we experience matches that prediction, then everything feels fine. So this is the checkerboard illusion. So this is based on the fact that in our previous life, a shadow being cast across a tiled surface will change the shade of tiles beneath it. So tiles A, B, look to be different shades on the left picture. When you draw a line between tiles A, that you can see that they're actually the same shade. I don't know about you, but when I go back to the first picture, tiles A and B are definitely different. So I have checked this. So I've done a screenshot to tell and say they're B. And I was a bit nervous doing this because I thought it was going to mess up my talk if they are different, but they are exactly the same. And so this shows how powerful illusions are. And we can relate that to FND as well. So often as doctors, when we tell people that their investigations are okay, their scan's clear, we hope that that's going to break the illusion of their symptoms, that they're going to disappear. And sometimes that can be the case. But in other situations, even though the patient knows that the tests are okay, they still experience their symptoms. And that's because of the power of this expectation and effect, which we get with illusions. And if you find that interesting, there's a TED talk by Professor Howard Seth about how your brain hallucinates your conscious reality. And then finally, another sort of piece of the jigsaw is fMRI studies, which are mostly done in FND for functional movement disorders. And these are all small studies, so we need to be careful about how we extrapolate from them. But these studies show that there's reduced activity in the right temporoparietal junction, which is a part of the brain that gives us a sense of agency or control over what we're doing. So we can put all this together. We've got a brain that can make mistakes under normal circumstances, and then something or nothing happens, and natural processes start to feel unnatural. So we move from our automatic, efficient processes to more conscious-led processes, to more likely to make mistakes. We have a reduced sense of control, and so it makes it hard to resolve the problem, and to the left with functional symptoms. So just coming back to my cases. So the first case was the young gentleman who was unwell with a chest infection, who'd been treated with a potential stroke. His symptoms flared up again a month later, and he went to ED where he got a completely different reception. Somebody told him that somebody with real symptoms could use a bed, and he was discharged. His GP tried to help by referring him to neurology. He rejected the referral, and then he was referred to psychiatry. He did see him, but didn't find any problems. And so he was left on his own with ongoing symptoms. He Googled things, found one of my local peer support groups. He suggested that he asked his GP to refer him to us, and his GP agreed. With our second lecturer, she's a 65-year-old lady who'd got a background of chronic fatigue and then acute onset of cognitive symptoms in the context of social embarrassment. She'd seen loads of people, so she went to the eye hospital, had every test done with the sun, and they were all normal. She'd been to the general neurology clinic. She'd seen two of my colleagues in the cognitive neurology clinic. She'd had appropriate investigations which didn't find any problems, and she was diagnosed with functional cognitive disorder and referred to us. So I'm going to come back to them again. And Jay told me that he had a little look through my slides and thought this was controversial. So to say this in front of a room of psychiatrists. But so in general, I'd say that FND should be diagnosed by a neurologist because it's not FLD. It's some other neurological condition which might be rare or unusual. However, we do accept referrals to our service. So our service criteria are that the diagnosis has been made by just, we do accept referrals from stroke physicians, for example, because 8 to 9% of stroke hesitations are FND. So we're confident that they are good at assessing for the differential functional neurological disorder in that context. And similarly, we'd accept referrals from psychiatrists who are confident about the differentials from functional cognitive disorder. So it must be diagnosed by somebody who knows what they're dealing with. And functional symptoms evolve. Having FND doesn't make you obese, developing other conditions. And as I said, it's important not just to level things in with the FND diagnosis. And so just thinking about how we make the diagnosis, it's largely based on the history and examination because investigations are going to be negative. That doesn't mean that we shouldn't do investigations. It's important to do investigations to rule out functional mimics and then identify any physical triggers or a dual diagnosis with a lung neurological condition. For functional weakness, we use the Hoover sign, and there are tables like the one I've got here, of characteristic features of functional seizures that helps distinguish them from epileptic seizures. And then there are features that you'll all recognise from the clinic that we see where people have functional cognitive disorders. So they tend to attend on their own. They tend to be more worried about their symptoms than other people are. They tend to give very detailed accounts. They're often talk for more than a minute. That's the first question. And they will include specific examples about their cognitive failures, often gaps in their autobiographical memories. It would often relate to a lot of the cognitive lapses that they're describing and think, I think that's normal, I hope it is. They'll often describe sort of variable faults rather than the next progression of a degenerative condition. And their symptoms might become more prominent in specific situations, set up at home or work. And we talked about biomarkers today, and as I said, it is okay to investigate, to perform investigations when you're suspecting functional cognitive disorder, but you need to think clearly about why you're doing it, what you're expecting to find, and talk that through with the patient so that negative tests are a positive finding that supports your clinical diagnosis, not that the tests are negative, so it must be FND, because that feels a bit like a cop-out to the patient. And also being aware that we know that scans can be normal, that people have got a very symptomatic with degenerative disease. And there are studies that show that people with subjective cognitive repair, they can have HBL their scans and they don't go on to develop dementia. And there are PET studies with 46 to 86% specificity, which suggests that 28% of their positive scans did progress to dementia. And And this is taken from another of Wessex papers, and a study there that was talking about if we get positive biomarkers in the context of subjective cognitive impairment, clinicians are much more likely to start predicting future decline. You might think about performance validity tests as being a helpful feature in FND. So we think that there's going to be poor effort or negative response bias. There's another study by Laura McWhirter that shows that this isn't a reliable finding. So people with FND might fail PVTs, but they might also pass them. And people with degenerative conditions can fail PVTs and can pass them. So they're not as definitive as we might like. And so there's been this increasing push to develop better diagnostic criteria. And Laura, Harriet and Veronica have all published on this recently. Most recently, Veronica, who's done a Delphi study with 45 experts from around the world, looking at consensus statements to try and come up with a checklist that'd be helpful in practice. So the top three are the ones with the most consensus. I can't read that. But I think there's a discrepancy between what they're reporting and what they're able to do, variability. I'm getting specific examples of their cognitive lapses. And then as part of the study, we were all asked to apply this retrospectively to cases. And it was really good at identifying functional cognitive disorder. And so the next step will be prospective studies to see how helpful it is in practice. So returning to my cases, who got the first case, the young guy with chest infection and a stroke mode presentation, who was abandoned really. So I met him about 8 months after his diagnosis. And by that time, he was in a real fickle. He had cognitive symptoms, difficulty retaining your information, getting just disorientated, dissociative symptoms, speech problems, left-sided weakness, shaking episodes, falling over, and other problems. He was now depressed. He wasn't sleeping well. He wasn't at work, and everything was rubbish at home. And then with my second lady, so the 65-year-old, but with acute onset of cognitive problems, I met her about 4 years after the onset of her symptoms. We went through all of her symptoms and all of her investigations, and she remained convinced that she was developing dementia. She was really worried that she lived on her own, so she had no witnesses to her declining. She really, really wanted a lumbar puncture. We talked a lot about that because my colleagues at the cognitive clinic had elected not to do it. And she did acknowledge that she wouldn't be reassured by negative results, and she would want a lumbar puncture to be repeated on a yearly basis until it became positive. So I agreed with my colleagues that I didn't think it was sensible to go ahead. And she was living an increasingly restricted life. So what happens in functional cognitive disorder? So long-term studies show that people with functional cognitive disorder don't develop dementia. So on one hand, that's good, but pretty much all of them continue to have symptoms. So it's not a benign diagnosis. 50% of people become unemployed, and 73% of cognitive doctors discharge people from clinic without any treatment. So what should happen? So we had step care models to guide us in diagnosis made by a neurologist or other experts. He should give an explanation, and the explanation could be really powerful. So this is for functional seizures. So 28 patients prior to diagnosis have 14 GP visits, lots of ambulance calls, ED visits and admissions, and a ton of investigations. And they're just given a diagnosis, no treatment. And for 6 months after that, there are just 2 ED visits, no admissions, and just 1 scan. So people with MD, just like anyone else, they just want to know what's wrong with them, and there's some guidance on how to manage things. When people often ask me, how do I explain functional neurological disorders, functional cognitive impairment, and I find that question really difficult to answer because it's an individually tailored answer. We often fall back on the hardware software analogy, so there's no common with the online shoe, or it's a problem with the program that's running. Might talk about what's normal, so discussing this sensitively because they might feel that that's a challenge to their experience. And then there's some people relate to the other sort of computer analogy, that they've got lots of tabs open, they've got a busy life, lots of stress going on, doesn't leave them with much reserve to do the things they want to do. People will often relate to them not being able to perform as well when they're under pressure. So, for example, most people dry paid from work and often can't remember how they got there. But as soon as you've got a critical spouse or maybe a colleague in the car with you, you'll clutch the gears and make a bit more mistakes. And then talk a little bit about that negative spiral with over-attention and stopping doing things automatically. So give them an explanation that hopefully will make a little bit more sense, and then direct them to resources. So Neurosymptoms has a really comprehensive patient leaflet on functional cognitive impairment, and you might direct them to peer support groups, such as FND Friends that I mentioned before. And then you refer them for physical or talking therapy, depending on their symptoms. And if you're in a neurocentre, that's fine. But if you're not in a neurocentre, there are consensus guidelines for physio, OT, and speech and language therapy, which are available for free on the internet. And we tend to recommend that people who have cognitive behavioural therapy. But at the end of last year, the British Psychological Society published a briefing paper with more information about potential talking therapy approaches. And there's a section on functional cognitive disorder. And so we might consider cognitive behavioural therapy, psychodynamic therapy, acceptance and commitment therapy. And there are several trials ongoing at the moment looking at talking therapy, online therapy, and a workbook and a smartphone app. But in my experience, all of these approaches are really difficult because people can't remember from one session to the next. And actually, I would be interested in developing more of sort of a practical course, perhaps a course of occupational therapy, one-to-one work. I think it's potentially more likely to be successful. So now just thinking about the more complex cases that get referred to the Rosa Burden Centre. So we're one of the most comprehensive F&D services outside London. A multidisciplinary team with me and a clinical fellow starting in September, 2 neuropsychiatrists, although one of them is leaving, so if anybody would like to come and work with us, let me know, and a multidisciplinary team. This is our pathway, which is essentially we've got the diagnosis made, and then we have outpatient and inpatient services. And then coming back to our cases, so the young guy with the onset of multiple symptoms in the context of a chest infection, initially treated as a stroke, who was in a real mess by the time I saw him. We admitted him to our inpatient programme a month later, and he made improvement on the programme. And by the end of the year, realised that he didn't have much in the way of symptoms, and when I met him for follow-up, and in the January, he was having a bit of speech and language therapy, but was back at work full-time and had been promoted. So people often think that FND is a bit heart sink and we can't help these people, but for many people, we can help them get better. However, for the second case, we've really struggled with her. So we directed her to lots of resources. She is university educated and interested. She's read all of Laura McWhirter's papers as well, but remains unconvinced. We've set up some bespoke therapy for her with our liaison practitioner working with our occupational therapist, and she had some neuropsychology sessions as part of a pilot. But she remains convinced that she's got dementia, and so I've taken the pragmatic decision to continue to see her and follow up every 9 months. She feels safe because she's seeing me. She knows that I do FND, but she knows I also do a cognitive clinic. And I hope that I'm keeping her safe by preventing her from going down the cycle of further investigations with other people. So I'm coming to the end now. So this is just resources. If you're really interested in FND and want to do a lot of reading, there's a textbook published in 2016. If you're kind of interested and looking for a book to read on annual leave over the summer, I recommend It's All in Your Head, by Susanne Sullivan. She's got a little bit more controversial at late with her latest book, and people with FND don't massively like this book, particularly for the title. And it's a little bit sort of, there's always inner harmony. You'll get blind because you go through a divorce. But most healthcare professionals that I speak to who've read it found that it helps them reconnect with their empathy for people with FND, but also medically unexplained symptoms. If you've got less time, then there's a 2-sided essay published in Brain in 2022, actually won their inaugural Brain Essay Prize. Written by Stoya Popkaroff, who's a German epileptologist, and just writing about the importance of looking after people with FND. There's an international FND society, so it was set up about 10 years ago now, with 30 members, similar to your DLB group, 30 members, 50 members, and the conference last year had 2,000 people attending, and the next conference is in Baltimore in next June. That's it. So I hope that I've shown you that FND is common and cognitive symptoms are common. Well, saying that, they cause disability and distress. They cost to the individual, society, and the NHS. They have a poor prognosis. They're at risk of iatrogenic harm. So it's really important that we develop better diagnostic criteria and evidence-based management for them. And that's it. Thank you. Thank you. You're a mystic down, but really fascinating talk. I know I've learned a lot. We've got about 5 minutes for questions, if anybody has a question.
I wanted to ask about the service provision for functional cognitive disorder and whether there are any services available outside of your units across the country, but particularly loath for me to refer people to if we suspect someone has functional cognitive disorder in one of our memory clinics.
So I have to repeat the question, the other people online. So the question is about where can you refer people once you've made a diagnosis of functional cognitive disorder? There aren't any specialist clinics that I'm aware of. So we get a few into our cognitive neurology clinic because they know that me and Harriet are working there. And obviously I get them in my FND clinic, but I'm not aware of anyone. I don't think Laura has a specialist cognitive clinic, and there aren't really any other people working in the area. It's an area that's only really been sort of looked at properly over the last 10 years or so.
I've been interested recently into press coverage of functional neurological disorder, and I'm always, I always kind of think it's hard enough to talk about dementia in the press, but FND, I think, is a particularly interesting view. It's always talked about as a rare brain disease. It's always been misdiagnosed by somebody somewhere. I was wondering whether in your experience you find reporting difficult to patients or whether it's just raising an awareness so any coverage is better.
Yeah, so media coverage of FND. So yes, so I think until recently, as you say, it was often mystery disorders, and those of us who are familiar with FND would go, "Oh no, God, there's no mystery here." But I would say over the last couple of years, there's been a change, and people are now saying, "I've got this. It was a mystery illness, but now I know that I've got FND," I think. Raising awareness is really important. So people with FND have often never heard of FND before. They're surprised to hear that we would see 1 or 2 people with FND in a general neurology clinic every day, and they feel very alone with their symptoms. And we talk about the stigma that healthcare professionals have for FND, but often patients will have a bit of apprehension about receiving the diagnosis as well. So referring them to peer support groups could be really helpful. We've got a really great one across the southwest called FND Friends, who are a really positive group of people who do a lot. And so I think raising awareness is important, and I think encouraging people to make the diagnosis and not leaving people feeling like they're a mystery or that they've got something unusual going on. It's better to make a positive diagnosis.
I just wondered if you had any comment on what might push someone towards a functional neurological disorder as opposed to a functional cardiac or GI, because people can present obviously with a number of different symptoms.
Yeah, so people with FND are more likely to have other similar symptoms affecting other systems. And there is a bit of a move to adopting the functional term in other specialties. So people talk about functional bowel disorders as well as irritable bowel disorder. It gets a bit complicated because urologists talk about functional problems that they're not what we understand as functional problems, they're mechanical problems. So you need to be a bit careful about terminology. But there does seem to be overlap. And I think this is one of the hazards of Western medicine, where we all work in silos separately and don't talk much to each other. And so somebody ends up seeing a cardiologist about their POTS, a gastro person about their IBS and a neurologist about whatever. In Bristol, we have a medically unexplained symptoms clinic run by Kate Seddon, who's a liaison psychiatrist. And once somebody's experiencing that family of problems in multiple systems, she'll see them because there's more likely to be some psychological factors there. And we're actually working across Bristol, so hopefully in November we're going to have our first meet-up of specialists who work in all of those different areas, so that we can get together and have a look at whether there's common themes, common causes, and then looking at pathways, whether there's overlap in our approaches, in business cases. So I think it is interesting, but I am careful I wouldn't diagnose somebody with fibromyalgia in the FND clinic. I would say that they need to go get a specialist opinion for that, and I'll talk to people about chronic pain, but I'll recommend that they're referred to a chronic pain specialist, because I think there's too much to know about all of those things for me to be able to manage it in the one clinic.
Okay, thank you.
Thank you very much. I think that's all we've got time for question-wise today, so thank you for your talk. Fantastic.